I'm Dr. Flores. I'm one of the San Diego Fertility Center fertility specialists. Today I wanted to talk about the diagnosis of polycystic ovarian syndrome. So this is actually becoming much more common in terms of a diagnosis, and sometimes the diagnosis in and of itself can be a little bit daunting and a little bit hard to really understand what that means. So one of the first things that I wanted to talk about is what is PCOS? The term comes from polycystic ovarian syndrome, and that's because when it was first described, what was noted is that women had not so much that they had cysts on their ovaries, but they had multiple follicles on their ovaries. But it's really a constellation of symptoms. And so in order to actually diagnose it, individuals have to meet 2 out of 3 criteria. The first is irregular cycles, but it's important to recognize that there are a couple of things that can cause an irregular cycle. And so before we say that it's related to PCOS, we do some extra hormonal profiling. So we'll check something called a prolactin. That's a hormone that comes from the brain. It's normally high in preparation for breastfeeding, but it can be elevated outside of that. And so if that's elevated, it can also cause irregular cycles, but is not a PCOS diagnosis. So we'll check a prolactin. We'll also check your FSH and your estrogen levels. That's getting a better idea of how the brain and the ovary are communicating with each other. Individuals with PCOS or individuals with irregular cycles may also have irregular cycles due to an elevated thyroid hormone. So we'll also check your TSH or thyroid stimulating hormone to see if that's contributing to the irregular cycles. And then if those are normal, we'll do the panel all at once so you don't have to come in for multiple labs. But if those are normal, then what goes along with the diagnosis of PCOS is we also will check your testosterone level. So all women have testosterone, just like men, but our testosterone levels are lower. And so if our testosterone levels are a little bit higher than the cutoff for women, that also goes along with the diagnosis of PCOS. There is another condition that can mimic polycystic ovarian syndrome, and that is a condition from the adrenal gland. It's called late onset congenital adrenal hyperplasia. The adrenal glands are these small little glands that sit on top of the kidney. They can also make a lot of male type hormones, and so we check a hormone called 17-hydroxyprogesterone because if that's elevated, again, it's not PCOS, it's actually an adrenal condition, and the treatment is different. And we'll get into that actually a little bit later. But in addition to also doing the lab profile, we also will do an ultrasound. So again, the name polycystic ovarian syndrome is a bit of a misnomer because they're not cysts, they are follicles, and the follicles are what house the egg. But what we're looking at is it's classically been defined as a string of pearls. So if we look at the ovary, if my 2 hands together are the ovary, what we'll see is along the periphery of the ovary, it looks like a string of pearls. So you see all of the follicles are kind of on the outer aspect of the ovary, and then the other part of the ovarian tissue, which is called the stroma, is a little more prominent. So to meet 2 out of the 3 criteria, again, it's irregular cycles that we can't attribute to things like an elevated prolactin or an elevated thyroid hormone, either polycystic ovaries, or the clinical or biochemical signs of excess androgen. So that's either we see an elevated testosterone on blood work, or you yourself note that you have a history of a lot of facial hair or a lot of acne growing up. So meeting those 2 out of the 3 criteria, it's actually called the Rotterdam criteria. And it's important to diagnose because PCOS has implications not just for fertility and the treatment options that we recommend, but also your overall health. We do know that women with polycystic ovarian syndrome are at risk of having diabetes. So once we make that diagnosis, we'll also check a hemoglobin A1C. That's giving us an idea of how your body's able to handle blood sugar. If it looks like that's elevated, we'll prescribe you a medication called metformin that will not only help along your fertility journey, but also your overall health. So once we get that diagnosis, then we start talking about treatment options. From the perspective of fertility, a lot of patients with PCOS don't always ovulate regularly. So the first goal is to get ovulation to happen. And the reason why we want to know if it's PCOS or not is because we do have 2 agents that are available for leading to ovulation induction, or essentially leading ovulation to happen. One is called Clomid, and the other one is called letrozole. Both are oral medications, but Clomid has been found to work better in patients who don't have PCOS, whereas letrozole has been found to work better to not only get ovulation to happen, but also lead to a higher likelihood of having a live birth or having a baby. So once we make that diagnosis, if our first line treatment is going to be ovulation induction, the agent that we're going to use is letrozole. Now, we may or may not need to add on an intrauterine insemination as well. Again, with PCOS, the big thing from a fertility perspective is that ovulation is not happening regularly. So if we can get ovulation to happen, and in patients who have a male partner, if the semen analysis is normal, we can actually do a few cycles of what we call ovulation induction with the letrozole and timed intercourse. So you may not need an intrauterine insemination. However, if after 3 to 4 cycles pregnancy has not happened, at that point, again, even if the semen analysis is normal, we'll add on the intrauterine insemination as well. Or if you have PCOS and there is some aspect of male factor infertility, then again, we'll use the letrozole and also start off with intrauterine inseminations. Sometimes, even after that, and usually we'll recommend around 4 to 6 cycles of the letrozole, pregnancy may not happen. And that's okay. We have another treatment option available, which is in vitro fertilization. But the unique thing to consider is, again, patients with PCOS do have a lot of follicles. So when we're stimulating the ovaries with in vitro fertilization, we want to make sure that we do so safely. And what I mean by that is patients with PCOS are at a higher risk of having ovarian hyperstimulation syndrome. It's a bit of a double-edged sword because on the one hand, it means that you have lots of eggs, which is great, but part of the reason why we monitor you so closely with IVF is because we want to make sure that you're not hyper-responding, meaning that, yes, we want to get a good number of eggs so that we can have a good number to fertilize and ultimately lead to several embryos, but we don't want to do so at the risk of your overall well-being. So again, the diagnosis becomes important because it does help us decide on how we're going to navigate your fertility pathway. If it's ovulation induction and intrauterine insemination, then we're going to use letrozole and not Clomid. If it's in vitro fertilization, we just always want to keep in the back of our minds that ovarian hyperstimulation is possible, but we'll adjust your protocol in such a way so that we minimize that risk for you.